Hello students, good evening. So today is our discussion on the May INISS Neurosurgery Recall. So as our next INISS is in November and we have to know certain points for the INISS exams, as we have already discussed that the first thing before INISS, whatever subject you are taking, neurosurgery, gastrosurgery or any other surgery, 3-4 days prior to exam you just have to revise that particular part and that particular topic. Suppose you are preparing for neurosurgery November exam INISS, 3-4 days prior to that, as I have already told you, just read neurosurgery notes, neurosurgery previous questions, and the books and the charts from the Human, Greenberg, and De Jong book, that is your neurological examination book, and few points from the anatomical neuroanatomy before the exams 5 to 6 times, only neurosurgery 5 to 6 times prior to your exam. Okay, so generally, this is your rank deciding subject. The 30 questions that will be from your general part and mixed surgery part, it will be a very basic exam. If you have read it thoroughly in your 3 years and prepared it from any app, it will be easier for you. But the subject that is important, that you are targeting, from that you need to be 10% or 100% sure. It's like if there is 50 questions, you have to get 48, 49 questions correct. Okay, so sometimes what happens is there will be lots of repeat questions, similar questions. In the last 10 years paper, some questions will be repeated, and certain trends are changing, like some new diagnostics are coming, some new genetics are coming, some new trends are coming. So what is happening, you need to recall and know about all those things. So in this class we will just go through quickly in the May, from the May INISS Neurosurgery Recall, and what points you need to go through before the exam. So I suggest you go through the exam, this paper, just once or twice, just in case some questions click. Okay. So the questions that I have made it is from, like I have taken the recall questions from the students who have appeared the exams, and they have given us the recall questions, and from there we have corrected the data, and from the data we have made this presentation. Okay. So there will be some general surgery questions also and maximum neurosurgery questions. Some topics have been covered in our classes also. I have already taught you. Okay. So the first question, some image was given as told by the students, that it was asked to identify what triangle it is. You know, in general surgery, there are many triangles, many scores, many trauma updates, and also many your charts and updated things like your trauma, liver trauma, kidney trauma, spleen trauma. So this is a basic diagram or your image or a triangle showing your general surgery hernia part. When you are reading the anterior abdominal part or the hernia part, you see such questions come. Like there will be options: triangle of pain, triangle of doom, okay, then the quadrangle of disaster, and the triangle of Hasselbalch's. So all these triangles we have encountered in our general surgery. So what is this particular triangle that the student told us, that this triangle was particularly given with a deep ring and a superficial ring? You can see there will be iliac artery and iliac vein. There will be medial border by the ductus deferens, the lateral border by the gonadal vessels, and there will be a genital branch of the genitofemoral lobe. So what is the answer? So the answer here is the triangle of doom, which has a medial border of ductus deferens, lateral border of gonadal vessels. Contents are the external iliac artery and vein, and also the posterior boundary is by the peritoneal reflection. So this area contains major vascular structures like the external iliac vessels, and so no fixation of the vessels, like your mesh has to be done. So if suppose this question comes in your next exam, but there is slight changes, okay, they may ask you why there won't be any fixation of mesh, because there will be this major vascular structures in this triangle, and also there will be tacks and staplers which should be placed here because it can lead to life-threatening condition. This should not be kept. So there will be also the triangle of doom. How do you differentiate it? In the triangle of doom, there will be a femoral part of the genitofemoral nerve, as it is here the genital branch. So there will be similar triangles, and these triangles you have to be correct. Okay. Next, as we have discussed in our neurovascular surgery classes in detail, the question has come: a small AVM in the thalamus of size 3 cross 1 centimeter with DSI showing multiple small feeder vessels, and what is the management? Craniotomy with excision, angiographic or particulate embolization, gamma knife, wait and watch. So we have already discussed about all these type of modality of treatment and how we have the Spitzer-Martin score. Please go through the Spitzer-Martin score. Okay, so in this case, as it is a deeper structure and also there will be multiple small feeders, there might be having the Spitzer-Martin score of more than 4 or 5. Okay, so what will happen? The surgical treatment is difficult in this process. In this process, the surgical treatment will be very difficult because of all these associated things. Small feeder vessels, there will be the thalamus, which is a vital structure. There will be a chance of bleeding. So what next option we have got? The next option that we have got is your gamma knife. Thalamic AVMs are deep-seated, surrounded by your critical neurovascular structures. So microsurgical exception or excision, that is the option A, carries very high mortality rate due to the deep location that is not preferred. So embolization option B is usually adjunctive. Like embolization we generally don't do in AVMs. Okay, I have told you if there is an aneurysm, also the aneurysm is not approachable by your surgery. If there is a wide dome to neck ratio, then we go for your coiling, that is your endovascular or your embolization. Okay, so in this case, in the AVMs with multiple feeder arteries, embolization is not a good option. So next best option is your gamma knife. So gamma knife is the recurrent or your now the emergent condition or emergent therapy that has come. Many neurosurgeons after completion of their this degree, they are going for a short-term course like fellowships in your gamma knife also. So gamma knife is very useful in these conditions. Where else the gamma knife is used? In small CP angle tumors less than 2 centimeter. So in all these cases, your gamma knife is used. So observation, that is your option D, is not preferred because deep AVMs have higher rupture risk. Okay, so for small deep AVMs less than 3 centimeter, SRS, that is your gamma knife, that is your stereotactic radiosurgery, in short, is the gold standard with best safety and obliteration rates. Next question. Part of the ventricular drainage, which is the most resistant to dilatation ongoing the hydrocephalus or during your ongoing hydrocephalus, which is the most resistance to recalled by the students were aqueduct of Sylvius, third ventricle, lateral ventricle, and the fourth ventricle. So the answer will be the A, aqueduct of Sylvius. What is the aqueduct of Sylvius? As we know, there will be your lateral ventricles. They will drain to third ventricle by the foramen of Monro. From the third ventricle, they will go to the fourth ventricle by your aqueduct of Sylvius. So you can see this will be your lateral ventricle. They will go by the foramen of Monro to the third ventricle and by the cerebral aqueduct to your fourth ventricle. Okay, so this is your cerebral aqueduct. It is the most resistant to your dilatation. The aqueduct is a long, narrow, rigid canal between the third and fourth ventricles. It does not dilate in your hydrocephalus. It gets compressed instead. Lateral and third ventricles enlarge significantly in obstructive hydrocephalus. The frontal horn and the posterior lateral horns are the most first structures which get enlarged in your hydrocephalus. So this could be the next question in your next exam. So what structures first dilate in your hydrocephalus? The frontal horns of your lateral ventricles and the posterior horns. And then the fourth ventricle may dilate depending on the obstruction level. Thus, the aqueduct of Sylvius is the most resistant to your distension. True statement after rhizotomy. What is rhizotomy? Rhizotomy is cutting of the nerve. So when do we do for the rhizotomy? Generally, we don't go for rhizotomy. It will give rise to your nerve decompression. Like you will have the loss of nerve function. Is it done in 2 levels and below the involved pain region? for intractable pain, bilaterally done for pelvic cancer pain, and also C4 to T1 should have useful upper limb. Okay, so these are the statements that was given by the students. So the answer is for the intractable pain. Rhizotomy is cutting the sensory root. Okay, usually used in your intractable pain, as we have studied about the surgical options of your neurosurgery, rhizotomy. Option A is false. It is not specifically 2 levels below the pain area. Option C is also false. It is not done bilaterally for pelvic cancer pain. Okay, and would cause severe sensory loss plus bowel and bladder dysfunction. And option D is unrelated. As you can see, there will be upper limb function will be their criteria applied to chordotomy and not the rhizotomy. It is about the chords, that is your brachial plexus. Okay. So therefore, the only correct statement among the given options was used for the intractable pain. So this was an easy question. There will be some questions which are common to all, which will be easy and answered by all. But if you do wrong in these questions, then you don't have a chance of getting the top ranks between 10 and 15. So it is important that you don't do mistake in the simple common questions which everyone will do right. Okay, so the next question: during the transpenoidal surgery or the endoscopic transnasal transpenoidal surgery for the pituitary tumor, which structure can be commonly injured superiorly? Optic chiasma, cavernous sinus, internal carotid artery, that is your ICA, and the clivus. So you all know that we have got a pituitary here. Okay, there will be nasal. Here there will be eyes and the face. So you can see we will have an endoscopic approach. You can have here bilateral optic tracts, optic chiasma. You can also have your ICA. Here there will be clivus. So all these options are similar, but what to know, what is important, what you can damage when you are doing this endoscopic procedure, what common structure can come. Okay, so the answer is optic chiasma, because it is just first the structure that comes when you are doing the endoscopic sinus surgery, optic chiasma. Then the other things, you can puncture cavernous sinus also, but the answer here, what comes first that can be damaged, is your optic chiasma. Anyways, in your pituitary surgeries, there will be already a compression on the chiasma. There could be some bilateral your vision problems. There could be bilateral optic atrophy. There could be bilateral blindness. So optic chiasma is the first structure to get involved. The optic chiasma lies just superior to the pituitary gland. During upward dissection or tumor removal, especially in the macroadenomas, the chiasma can be stretched or injured, like the visual field defects can be there. The cavernous sinus and ICA are lateral, not superior. The clivus is inferior or the posterior, as I have told you. Thus, optic chiasma is the common superior structure at the risk. I suggest you go through every question 2 times, just read. There could be some words either or neither, either or, some language type of questions, and it will be like you think this is the answer, but it will be asking you something else. There will be like a protocol type of a thing. There could be like a confusion of options. There could be like one option is 90% correct and one option is 80% correct. So you have to think a lot, and also there will be time limit, like there will be 90 minutes and 80 questions, and there will be like a jumbling of your thoughts in the exams. Like you will be thinking that this could be the answer 80 or 90%. So I suggest you be calm and go through the questions thoroughly. I hope you will know everything. You can recall everything. All the following are ATT drugs are bactericidal except. So this is a question that we should not do wrong. This was in our SPM also, medicine also, and generally also we should know about all these things. Streptomycin, ethambutol, isoniazid, rifampicin. So as we all know, thus the answer is your ethambutol. Isoniazid, rifampicin, and streptomycin are your bactericidal, whereas ethambutol is your bacteriostatic. So ethambutol inhibits your arabinosyl transferase, which is the cell wall synthesis inhibitor. Okay, so that is your bacteriostatic, but it does not kill the Mycobacterium tuberculosis directly. Okay, so this is a basic question. Most common brain tumor in AIDS patient. So this is also not from the neurosurgery view, also from your general medicine view, or also from your SPM view. This is a common epidemiology question. What is the most common brain tumor in an AIDS patient? The options were glioblastoma, lymphoma, ependymoma, astrocytoma. So the option that is correct is your lymphoma. And what lymphoma? Whether Hodgkin's lymphoma or non-Hodgkin's lymphoma? Non-Hodgkin's lymphoma is the lymphoma that is more prominent in your AIDS patient. Primary CNS lymphoma, non-Hodgkin's types, that is your Epstein-Barr virus associated diffuse large B cell type is the most common CNS tumor in your AIDS patients. So gliomas and ependymomas are not associated. Any tumor can occur in any person, but in AIDS people, most common infection are your opportunistic infections like your TB, cryptococcuses, and all those things, and with toxoplasmosis also. And when it comes to brain tumor, ependymomas, gliomas, everything can occur. But according to your statistics, lymphoma, non-Hodgkin's lymphoma, they are more prone to this AIDS or the immunocompromised patients or whose immune status is not good. Okay. The most common offending vessel in your hemifacial spasm. Is it pica? Is it ica? Is it vertebral artery or is it basilar artery? So this is a fact-based question. You cannot do anything on that. You just have to revise and remember the facts that are given in the books. I hope you must have gone through these tables in your Greenberg and your UMass. Certain syndromes will be there, certain obstructing vessels will be there, like the trigeminal neuralgia and all those things. So certain nerves will have certain attachments to certain arteries, and those will compress these nerves and there will have some pain. So hemifacial spasm is because of the seventh nerve compression, and it is compressed by your ICA. So the answer is ICA. ICA is a branch of your basilar artery, anterior, interior, inferior communicating artery. So ICA most commonly compresses the root exit zone of the facial nerve. Okay, anterior, inferior communicating artery. Pica is the next most common. Vertebral artery and basilar artery are less common. Anything can occur in serially, but the most common thing will be ICA. Like in your trigeminal neuralgia, it will be pica. So we have seen cases where there will be trigeminal neuralgia, the vertebral artery and basilar artery compressing the fifth nerve. But the most common things that has been asked in the exam, the answer here in this question will be your ICA. How will you differentiate a clival chordoma from a clival chordosarcoma on MRI? This was a difficult question that was come in the exam. The options were quite similar, like calcification, bony destruction and invasion, central contrast enhancement, and peripheral contrast enhancement. In both these situations, similar MRI images will be there. What was the striking feature here was in the chordoma, there will be central your enhancement. And in the chondrosarcoma, there will be peripheral enhancement. So the answer here will be C, central enhancement. When you see the central enhancement, you can see that this is chordoma. If peripheral enhancement, you can say it is your chondrosarcoma. Rest other are common in the both. But chordoma has central classifications and chondrosarcoma has peripheral classifications. So this is a fact-based and also theory-based question. It's a difficult question because while reading, you don't differentiate these two things. And it will be, I think this is a tough question which has come in the exam. The patient underwent thoracic spinal decompression stabilization surgery, after which he developed bilateral lower limb weakness and also hyperreflexia. So what would be the diagnosis here? So he already underwent surgery and post-surgery he is having all these kind of problems. Anterior cord syndrome, central cord syndrome, posterior cord syndrome, conus medullary syndrome. So the answer here will be anterior cord syndrome. During thoracic decompression, suppose the anterior spinal artery and ischemia, it can occur because of the pressure, okay, which leads to bilateral weakness, that is your cortical spinal, okay. Next, there will be hyperreflexia, which is also a sign of your anterior problem, not the posterior column problems because of the anterior column problem. Okay, there could be loss of pain and temperature, vibration and proprioception are being preserved. That means the posterior columns are okay. The posterior columns are okay. Okay. So the posterior cord syndrome gives loss of vibration and not the motor deficit. So because here the motor deficit is more common, so the answer would be your anterior cord syndrome. A patient with dominant parietal lobe tumor was given a matchbox and cigarette, and when asked to light the cigarette, he was rubbing the cigarette on the side of the matchbox. So, what is this known as? Okay, so this is like a task was given to the person, and he was doing this way: ideomotor apraxia, ideational apraxia, constructional apraxia, and prosopagnosia. This is a type of your neurological question. This is the type of your examination and your neurological question that the patient was given, like there was like parietal lobe function test, and he was given this to light the cigarette, and what he was doing, like this some action he was keeping on doing. So the doubt was here between the ideomotor apraxia and the ideational apraxia. So the answer here is ideational apraxia. Ideational apraxia is the inability to perform the multi-step task and to process what the examiner is saying, sequencing problem. Okay, but when it comes to ideomotor, cannot imitate or perform gestures like I light the cigarette, he is not able to do. But when I tell him to do and he's not able to process and do, it is ideational. Suppose I am showing him to drink a tea and he is not able to drink a tea, means it is ideomotor. Generally, the confusion was between the ideational and ideomotor. Rest two are different from this example, like the prosopagnosia, like the face recognition problem, and construction apraxia, like the spatial drawing problems, could also be there. A patient with systolic BP. This is the next question. 110 mm mercury and diastolic BP was about 80 mm mercury, and ICP, that is the intracranial pressure, was 20 mm mercury. What will be the CPP? That is your cerebral perfusion pressure. Okay, so some options were given. So here we know the equation, that is your CPP is equal to MAP minus ICP. This is a standard equation. CPP is equal to MAP minus ICP. So MAP is your SPP into 2 into diastolic BP by 3, okay, which is 110, plus 2 into 80, 160 by 3, which is about 90, and also minus your 20, that is already given in the exam, that is the intracranial pressure will be your 20. So what will be your CPP? 90 minus 20, that is your 70, which is the option B. So the answer is option B. This is a simple math and simple equation question. Next question. Axial right temporal region contrast enhanced MRI image was given with a space occupying lesion on the right petrous part of the temporal bone which projecting anteriorly, and it was said in question that it is difficult to differentiate here between chondrosarcoma and also paraganglioma. This is a very difficult and sequential question. Please go through it 2 times. Which nuclear scan will help identify the paraganglioma? So already it has given many things in the question, but the question output is very simple question. What nuclear scan you will use for paraganglioma? Okay, Lou-Dotanic scan, DWI MRI, FDG PET, and bone scan. Let us go through these scans. What is the DWI MRI? Diffusion weighted imaging. Where it is used? It is used for stroke, abscesses, and all those things. FDG PET, you know, it's mostly for your PET is for your cancer. Next, bone scan is for your osteoporosis or any malignancy in the bone. So the next option is your Lou-Dotanic scan. If you don't know about this scan also, you can rule out the 3 options. So ruling out the other options is important for your exams, and you can derive at the answer, that is your Lou-Dotanic scan. Okay. So paragangliomas express somatostatin receptors, that is your Dotanic. PET is highly sensitive for cancer. FDG PET is non-specific. Bone scan is not useful here, and also DWI cannot differentiate reliably. So the answer is your Lou-Dotanic scan. This is also used in your adrenal gland tumors, same paragangliomas and gliomas, and your adrenal gland some tumors. The same scan is used. So actually, the point is you have to rule out the options. Next question. A child presented with upward gaze palsy, okay, and was asked about, basically the question was about the Parinot syndrome, okay, and there were some kind of options like what this could be, like your tectal plate glioma, diffuse midbrain glioma, dorsally exophytic pontine tumor. Some options were given, some difficult options, but this was basically about the Parinot syndrome, that is the upward gaze palsy because of the tectal plate glioma in the midbrain. Because of the tectal plate glioma, there could be Parinot syndrome. This is covered up in your anatomy, and also the brainstem syndrome classes. Parinot's dorsal midbrain syndrome due to compression of the vertical gaze center in the tectum, that is your pineal region, that is your midbrain. Tectal glioma is the most common cause in the children. Okay. Midbrain has two parts, tectum and tegmentum. So coming to the next question, which skeletal dysplasia is a cause of spinal canal stenosis? Achondroplasia, polyostotic dysplasia, diffuse idiopathic skeletal hyperarthrosis, that is your DISH, which is also known as your DISH, and also osteopoikilosis. Okay, so DISH. So you must know what these terms are and where the diseases occur. So the answer here is achondroplasia. Why? Because there will be short pedicles, narrow spinal canal, lumbar stenosis, and also others do not cause congenital spinal stenosis. So the answer where will be achondroplasia. Some questions will be fact based. You cannot do anything on that. We have to just go by the fact and theory. And some questions will be a ruling part, okay, ruling out. And some will be our luck based questions. Luck factor will come there, okay. Patient with C5 C6 disc prolapse presented with the right upper limb radicular pain. Which nerve will be responsible for carrying this pain? You must be knowing about the dermatomes of your upper limb and lower limb. This will be a common diagram in your neurological books also. So upper limb pain, it could be in our lateral aspect, it could be in our medial aspect, it could be in our arm, it could be in our forearm. So we have to know what it is asking. It is asking there will be a C5 C6 disc prolapse is there, and also there is a upper limb radicular pain. It has not specified any medial aspect, lateral aspect, upper part or lower part. So what nerve will be responsible? C4, C5, C6, C7. So the answer here will be C6. Why? Because disc herniation compressions the descending nerve root. So in the cervical canal, if there is a C5, C6 disc, means it will compress the lower nerve root as per the equation. So the C6 root will get compressed. Okay, so the symptoms will be pain radiating your radial forearm to the thumb, also weakness of the biceps and wrist extension. There will be problem in the wrist extension. So there will be these type of questions which are easy to know, but there will be some problems. So what it is, if there is a disc, it will compress the lower nerve. C5, C6 means it will be C6. The question may come that there will be the pain in all these structures. So what is the nerve related? Sometimes there will be problem in the wrist extension and some flexions and all those things. So it will be C7. Finger flexions only C8. Okay. Next question. Which famous political personality had a history of intracranial aneurysm and he has undergone a aneurysmal surgery? Donald Trump, Joe Biden, Jaswant Singh, and also John F. Kennedy. So this was a KBC type question. So just I hope your guess comes right like in KBC. So the answer is Joe Biden. Joe Biden had two intracranial aneurysms treated surgically in 1988. Okay, so who is Joe Biden? He is now the currently in the last 4 years the US president. Okay, so you might not be knowing such a prominent figure had aneurysm, which is a very dangerous thing as for our curriculum and course, and also surgery. And also the surgery is also difficult thing, but well, he survived the surgery and now he's doing so well. So this was also a question which came in your exam. Next question. A person who works in office sitting on a chair for long hours presented with complaints of low backache and tingling sensation along the right sciatic nerve. What is the sciatic nerve composition or the nerve roots L4, L5, S1, S2, S3? Okay. This you have to remember in the anatomy. You are studying about this and reading about this since your anatomy classes. Also, there will be numbness along the right lower limb region and weakness of the extensor hallucis longus. Extensor hallucis longus means that your foot and the toe that will having the L5S1 or the deep peroneal nerve root. Deep peroneal nerve root. So, what level of pathology would you likely suspect here? L3, L4, L4, L5, L5S1, S1, S2. So the nerve levels you have to read, and the muscles and the joints it supplies, you have to remember it very thoroughly. So the answer will be L4, L5. Why? EHL weakness will have the L5 nerve root. So whether it will have the L5S1 or L4, L5, because there will be EHL weakness means L5 nerve root is already involved. Along with that, most common cause of L4, L5 disc prolapse, as I have told you, there will be a L5 pattern. The lower nerve root has been compressed. In L5S1, there will be your S1 compression. So S1 will have your ankle reflex negative. If suppose S1 is involved, means there will be ankle reflex problem. So here there will be L5 involvement. So lateral leg tingling and dorsal foot numbness will be there. Okay. So the most common will be your L4, L5 nerve root level. Also, you must have read about your central compression, lateral compression, and your far lateral compression of your nerve roots. True about PP9, protoporphyrin 9. This question was there in your exam. Multiple options were there. Some students said some options, some students said some other options, and jointly we derived at this question that about its absorption and some emission. The question was like the spectrum and wavelengths of the various colors were given in the brackets, like some absorbs blue, some absorbs green, emits red, blue, like that. So the correct answer is absorbs blue and emits green. What is protoporphyrin 9? Absorbs blue and emits green. It absorbs the blue light that is about 405 nanometer and emits your red pink fluorescence that is your 365 nanometer visible as your fluorescent tumor. It is like your fluorescent tumor. Okay. So, but in exam, the terminology was absorb blue and emit green or red like that, and also spectrum among the other given options. So A is correct, like you emits green. It was not given emits red, but we derived it emits green, or maybe the students were in a hurry, so they could not recall the colors correctly. So protoporphyrin 9 is the porphyrin scaffold of hemoglobin or heme B, a ubiquitous prosthetic group that is your of the proteins are also an antioxidant range and your all those things, radical scavengers, and also responsible for oxygen binding, that is your hemoglobin and bioglobin, and also that is your hemolytic, and also that is like your scavengers, oxygen scavengers, and also like your radical prosthesis, electron transfer, cytochrome C and catalysis, cytochrome P450, and catalase peroxidases, catalysis and peroxidases. So all these things have been there. So the among the options, we felt this could be the right option. True about vagus nerve are all except carries cranial part of the spinal accessory nerve, supplies suprarenal gland, left vagal nerve stimulation is used for your seizures reduction, and it is the largest cranial nerve. So options were similar, but what will be the correct answer? All were true except. So what is it? It supplies the suprarenal gland. All these other things are correct, but suprarenal gland it does not supply. Vagus nerve does not supply the suprarenal gland or the adrenal gland. That is, adrenal is supplied by the preganglionic and also the sympathetic fibers. That is your T10 to L1. Carries cranial part of the accessory nerve. Left vagal nerve stimulation is used for your seizures. Largest cranial nerve also, the thickest cranial nerve also, but it does not supply the adrenal. Adrenal is supplied by your preganglionic, parasympathetic, and sympathetic fibers. That is your T10 to L1. Because adrenal is used in our body for the flight and fight response, for epinephrine, norepinephrine. It has nothing to do with the vagus nerve. Next question. Not a component of your limbic system. Okay. Mammillary body, amygdala, cingulate gyrus, and pulvinar. So, among the options, the answer will be D, pulvinar. So, limbic system is a very common question that comes in your exam. I have shared with you an image of the limbic system also. You can see there will be a prefrontal cortex, there will be a cerebellum, and also there will be your cingulate gyrus, thalamus, hypothalamus, amygdala, and your hippocampus. So there will be your connections from your limbic system, that is your hippocampus. There could be connection to your amygdala, cingulate gyrus, the mammillary bodies, and fornix and septal nuclei. What is the work of this pulvinar, or what is the work of this limbic system? It is used as an association center. It is used in your memory formation. It is used as your coordination to work and your output. But pulvinar is present in your thalamic nucleus and not the limbic nucleus. Thalamic nucleus for the balance, for the posture, for the metabolism, all those things. So pulvinar is used in the or present in your thalamic nucleus and not the limbic nucleus. Next question. In an intubated patient on a ventilatory support, how many calories are delivered by active warming system, which is given in your Sabiston book, and it is like a general surgery question in the Sabiston book, a fact-based question, which was come in the exam method in your vent kilocalorie per hour. So the answer here will be 9 kilocalorie per hour. This is a fact-based question. All the following are secreted by your basophilic cells except GH, LH, ACTH, and TSH. So let's study about these options. So the answer is ACTH. How do we derive to this answer? So the basophil cells secrete FSH, LH, and TSH. Okay. Whereas the ACTH, actually the ACTH is from the corticotropes, which are basophilic. But exam traditionally classifies basophils are your FSH, LH, TSH, and acidophils are your GH and prolactin. Always GH and prolactin is your acidophils. So ACTH is your both acidophils, basophils. These are chromoform cells. So these are considered in many exam schemes as a combined thing. So and in all these options, we can rule out ACTH. Okay. Next question. Cervical traction. Okay. Applied or application is contraindicated in. What is cervical traction? We have studied. Suppose there is a listhesis. Suppose there is any spinal problem. Suppose this is the head. We put two pins and a cervical traction here. Okay. So where it is contraindicated? Where? Locked facets, type 1AC2 fracture, type 2 odontoid fracture, atlantoaxial dislocation. So it is your contraindicated in your locked facets. Why? Locked facets means there is an unstable injury. We have to go by the anterior approach of your spine injury, also the posterior approach of the spine injury. So the traction may worsen because we do not know the stability of the fracture. So this may worsen by the traction. Type 2 odontoid fracture, the traction will be allowed. Okay. And AAD, that is your atlantoaxial dislocation, also we can use the traction. Type 1AC2 fracture, also it is a type of stable fracture. So we can use the cervical traction. Okay. Next question. Most restrictive cervical orthosis, that is most restriction in your movement, is halo vest, Philadelphia collar. Philadelphia collar is nothing but your chin support collar used in your spinal surgeries. Chin support cervical collar. Okay. Somi brace, rigid collar. Rigid collar is also okay. You can have some kind of flexion extension. Somi brace is used for your some thoracic injury. You can use the Somi brace. So the answer here is the halo vest. Halo vest provides maximum immobilization, including rotation, flexion, extension. You can see here the halo vest and how there is restriction in all areas. So halo vest is the most restrictive kind of your vest, okay, or your orthosis. Next question. All the following are true about adult head injury except. Okay. So this is the type of questions that will have multiple options in the exams. You will be in a hurry. So you have to read these fast because otherwise so many lines and exam questions, you will miss them. Okay. So anti-epileptic prophylaxis is useful to prevent early post-traumatic seizures. Anti-epileptic prophylaxis is useful to prevent late prophylaxis seizures or late traumatic seizures. Anti-epileptic prophylaxis is not useful in preventing seizures in your penetrating head trauma. And anti-epileptic prophylaxis for 1 year is to be given for intracerebral bleed. Okay. So what is the correct thing in these things? Sometimes if you're not able to get to the answer, just skip the question, go to other questions, keep it for the recall, and at the end just come and read, and whichever option is about 90% 80% correct, just mark it. If you waste this question meanwhile, you will leave many questions at the end. So attempt till end, come back and attempt the questions which you think you can answer, but because of the time constraint you just have left it to think it at the last. So better to think at last. In between, if you think and you do something wrong, some easy questions also you might miss. Okay, so the answer here is anti-epileptic prophylaxis prevents the late post-traumatic seizures. So AEDs prevent your early less than 7 days seizures. Okay, this is useful. Do not prevent the late more than 7 days seizures. So it cannot be used to prevent all these things. If there is a seizures, onset of seizures, early seizures, we can use this thing. So the incorrect answer among all these things is your B. So if there is a penetrating trauma, if there is an IC bleed, if there is a tumor, there is a edema, in all these cases, we have to give anti-seizure medications. Prophylaxis is useful for 1 year. That is your anti-epileptic drugs for your ICH. That is your intracerebral hemorrhage is not recommended, but exam usually flags the B option. Okay. Components of Benedict syndrome. What is the Benedict syndrome? It is also a midbrain syndrome, are all except tremors, ipsilateral hemiparesis, ipsilateral cranial nerve palsy, that is your third cranial nerve, and also ataxia. So answer here will be your B, ipsilateral hemiparesis. Remember, in all the syndromes, the brainstem syndromes, let it be midbrain, pons or medulla, there will be always a contralateral hemiparesis. Ipsilateral cranial nerve palsy and contralateral hemiparesis. In all the questions, there will be a ipsilateral cranial nerve palsy and contralateral hemiparesis. So Benedict syndrome is a midbrain lesion, ipsilateral cranial nerve third palsy, contralateral tremor, contralateral ataxia, contralateral hemiparesis, not ipsilateral. So B option is your wrong. So Benedict syndrome, as you can see here in the image, okay, the correct answer will be easy in this option if you just put your brain, not just remember all the options, what was there in Benedict, what was there in Claude, what was there in Northanger, whether it was midbrain, pons or medulla. Just remember that contralateral hemiplegia can't be an option because it is in the ipsilateral hemiplegia, because it is in the ipsilateral side. The answer will always be in the contralateral side. That is your, this one will be your correct one. Next question. All the following uses photon as energy source except LINAC, gamma knife, SRS, and proton beam. This is also a fact-based question which you have to remember just. That's it. Okay. So answer is a proton beam, because proton beam therapy uses protons, not photons. Okay. It is easy. See, this is also answer in the exam question only. LINAC, SRS, that is your stereotactic radiosurgery, gamma knife, all are photon based, but proton beam is only proton based. Okay. Next question. True about brain abscess aspiration are all except mass effect is relieved immediately, hemorrhage is most common complication, local abscesses cavity installation with antibiotic should be done with after aspiration, as obvious from the option, after aspiration only you will give the antibiotic. Aspiration improves action of the IV antibiotics. And you all know, in the cerebral abscess there will be 4 stages of the cerebral abscess. Okay, early cerebritis, late cerebritis, early capsule, late capsule formation. Okay, so there will be 4 stages of your cerebral abscess. Okay, so in those type of questions you have to know basically what can be done and what cannot be done. So answer here is the B. Why? Most common complication will be recurrence, inadequate drainage, multiple abscesses, remaining of the abscesses, meningitis post-operatively, all these things, and not the hemorrhage. Hemorrhage is possible, but not the most common thing. Where is the hemorrhage most common thing? In AVMs, aneurysms, in tumors, there could be hemorrhage. But here in abscesses, the most common thing will be recurrence or re-abscess or your post-operative meningitis. Next question. Clinical photo of a left upper limb thinning or wasting was given with respect to right upper limb, as was told by the recall by the students, was given and in question, and it was mentioned that left upper limb motor weakness, and specifically mentioned that no sensory loss was there and diagnosis was asked. So what is this? Only a wasting of one side, and the diagnosis was vast. Brachial plexopathy, Hiramaya disease, syringomyelia, diabetic neuropathy. Diabetic neuropathy will have both lower limb, glove and stocking pattern, bilateral symptom. Diabetes and all these type of central diseases cannot happen with one area only or one side only. Okay, syringomyelia obviously will affect both the sides. Okay, now coming to the options between Hiramaya and also your brachial plexopathy. Young males with focal hand and forearm wasting, pure motor involvement, and no sensory deficits, which is important, causes you of your Hirayama disease or monomelic amyotrophic. This is a different name. This is also another name which is given in the books. That is your monomelic amyotrophic, that is your Hirayama disease. There is no sensory loss. If there is a sensory loss, we can suspect of your brachial plexus injury also. In the brachial plexopathy, almost always causes your sensory involvement. Syringomyelia dissociated, there will be sensory loss and not normal sensation. And diabetic neuropathy, sensory first and not motor only. And also it cannot affect one side, it will affect both the sides. Next question. One question was there. They had asked about the Asia impairment score and the Asia classification of the grading of the power motor of the patient with history of the recent spinal trauma, and left a lower limb power was something like 3 was mentioned specifically. So what it could be? Grade E, D, C and B. So I have shared with you an image of your or a chart of your Asia scale, which is also given in your standard books also, Greenberg and Human. I think it's also given in your this Bailey and also Sebastian. If not, also it's given in your standard neurosurgery books. So the answer here is grade D. Why? Asia grade D is more than half of the key muscles below have been injured, and also the power is more than equal to 3. Since power is 3 by 5 was specifically mentioned, that fits grade D. Grade E is normal function. Grade C would require power less than 3. Okay, so below the lesion. That's why we can go for the option D. But anyways, you have to remember this chart and table because they can ask from anywhere. Next question. All the following are true about pediatric TBI, traumatic brain injury, except children have higher seizure threshold than adults and hence don't need anti-epileptic prophylaxis. Children with mild head injury with no significant positive history don't need a head CT. Okay. Children have a lesser range of cerebral autoregulation and needs to BP control and monitoring. So the answer here is A. Children have less seizure threshold. That's why we are more worried about children. Anyways, anytime in a trauma center, we are always worried about children. Obviously, in the option B and C, you can see that if suppose the patient has come, a small child, there is a history of head fall, like fall from stool or chair, but there is no significant history. There is no need to go for any CT scan, but they have very less seizure thresholds. They can have seizures at any time. So we need to be very careful in children. Children actually have a lower seizure threshold, higher risk of post-traumatic seizures, need prophylaxis, mild head injury without risk factors, no CT needed. Okay, so pediatric autoregulation is narrow, strict MAP and CPP, that is cerebral perfusion pressure monitoring, has to be needed. So A is the false statement here. Not a component of your revised trauma score. So what is the revised trauma score? That some 3 to 4 trauma scores were asked this time in the May exams. We don't know what they will focus in the November exam. Okay, so revised trauma score, GCS, systolic BP, respiratory rate, and the heart rate. Okay, I hope in your general surgery videos and the general surgery classes, you must have read about all these scores in a rate or in a detail. So heart rate, okay. So revised trauma score includes GCS, systolic BP, respiratory rate. Heart rate is not included, okay. True about Sylvian Fisher arachnoid cyst are all except. These are the most common types of cysts. Bleeding within the cyst is always venous in origin. Cyst predisposes to seizures. Seizures can cause bleeding within the cyst. Minor trauma can cause bleeding within the cyst. So the answer here will be Seizures can cause bleeding into the cyst. It is false. Seizures cannot cause bleeding into the cyst. There could be bleeding in the cyst previously, but seizures causing the cyst or bleeding is very uncommon and rare. Okay. So hemorrhage is usually venous, true, because there will be a lot of venous drainage rather than arterial. If it is a AVM or arteriovenous malformations or aneurysms, it is because of the arterial origin. Cyst increases your seizure risk, it is true. Minor trauma can cause bleed, also it is true. Seizures do not cause bleeding. Okay, this is the false statement. Next question. Which of the following is incorrect for Sudden's classification of nerve injury, which was given in your neurological books, also neuroanatomical books, like your Vishram Singh and Ivy Singh also has this Sudden's classification of your nerve injury. Neuropraxia, detailed and correct long definition was given. Neurotomesis, detailed and correct long definition was given as according to students. Axonotomies, detailed and correct long definition. Some neurolysis, some wrong definition was given. When you know these three things are common, so this was already given. So mostly some neurolysis, some wrong option was given. Okay. So Sutton's classification includes only neuropraxia, axonotomies, and neurotomies. Neurolysis is not anyways a part of Sutton's classification also. So this is the clue. This is the clue because neurolysis is not included in your Sutton's classification. Okay. All the following are true about the brain hydrated cyst, which is also a rare disease, obviously, except Dowling technique is used, rupture causes recurrence, risk of anaphylaxis can be done endoscopically. So anywhere hydrated cyst will have similar complaints and similar treatment, but here the option that is wrong is can be done endoscopically. Endoscopically, we do not prefer to do hydrated cyst. Why? Because brain is already a closed structure. Second thing, it can cause to rupture and anaphylaxis. Third, we cannot totally take out by endoscopic this cyst. So this is the wrong option. Where do we use endoscope or where do you use a laparoscope? In your liver hydrated cyst, in your other organs hydrated cyst, but not in the brain. Okay, so Darling technique is your standard. If ruptured, you can get recurrence. Risk of anaphylaxis is true. So endoscopic removal is not recommended because cyst must not rupture, which is a false statement. Next question. Most common gene implicated in primary GBM. This is also a fact-based question. We cannot change it. We just have to remember this. And these type of genetic questions have come in the past 10 to 15 years multiple times. Several other questions might come like cavernoma, some gene factor, some other disease, some gene factor responsible for your this cutaneous markers, neurocutaneous markers for some diseases, skin and cutaneous markers. They could also ask you about this aneurysms and some markers. Okay, so P53, EGFR, IDH, BRAF, V600E. So the answer here will be your EGFR. In your primary GBM, EGFR amplification is the most common. Okay, glioblastoma multiforme. Whereas the secondary GBM or METs, P53 and IDH mutations are more common. Okay, and nowadays like in our college also, one of our senior assistants and one of our PGs are doing a research on these type of gliomas and GBMs and these relations with the gene factors. They're taking the blood tests and amplifying it and checking for the gene factors. Maybe in the next 5 to 10 years, we may get some kind of genetic relationship more about these tumors and some other treatment protocols to prevent the tumors. So this medical science is evolving and every department there is having some kind of research. In the long term, maybe 10-20 years from now, we may have some prevention for the brain tumors based on these genetic factors. Like for children nowadays they are decreasing the type of the congenital malformations because of the antenatal scans, prenatal scans and all these things. So all these things could be good for us also. Next, what is the external diameter of the Veris needle? Okay, this was a very uncommon question. I don't know whether they answered it right or wrong because the options were similar and sometimes you don't remember the needle also. So the standard Veris needle is 12 to 15 centimeter and outer diameter will be your 16G. Okay, so this is how you remember. They will ask you about your biopsy needle diameter, bone marrow biopsy, Veris needle. So Veris needle will be your 12 to 15 centimeter normal and outer diameter will be 16G. Next question. Laparoscopic TEP hernia surgery was first done by Duluc, Stahls, Michael Clark, and Billroth. Okay, Billroth, so anyways, is ruled out because it is having other pancreatic and other associations. Stahl is for your endoscopic and all those things. Michael Clark is for your gallbladder. So the answer here is your Duluc. Okay, Philip Duluc performed the first TEP, totally extraperitoneal repair. This was also a fact-based question from your general surgery part. Next question. True about thyroid oncogenesis. KRAS mutation seen commonly in radiation-induced thyroid neoplasm. RAS mutation seen only in malignant thyroid neoplasms, not in benign. BRAF mutations is most commonly associated with the thyroid neoplasms, and BRAF mutation is seen in your 40 to 50% cases of your papillary thyroid carcinoma. What is the true about thyroid oncogenesis? There have been many factors included in your thyroid oncogenesis, also in your um, other your endocrine organs like your pancreas and adrenal oncogenesis. So the answer is here is your BARF. BRAF mutation is seen in 40 to 50% of your papillary thyroid carcinoma. Option A, KRAS, is not commonly associated with the radiation-induced tumors. That is your false statement. Okay, so there will be multiple options and multiple relationships, and this is a very good question. And this question was also in my time 2 3 years back, NEET exam also, and also these genetic factors are more extensively given in your Sabiston about thyroid and the breast. Okay, in your Bailey also. So please just note it down. RAS mutations occur in benign, that is your follicular adenoma and malignant tumors are false. BRAF is not the most common mutations across all thyroid cancers. RA is the most common overall, that is the false statement. So BRAF V600E mutation occurs in 40 to 60% of your papillary thyroid cancer. This is the most correct answer. If you have solved multiple questions, you will get to the correct answer definitely. So the next question is, which of the following is not a pro-inflammatory cytokine? Interleukin 1, 4, 8, TNF alpha. So 1 and alpha are anyways your inflammatory cytokine. So see, the answer will be IL, interleukins 4. Interleukins 1, 8, TNF alpha are pro-inflammatory cytokines. Between the 4 and 8, 4 is your anti-inflammatory and promotes your Th2 pathway. So the answer here is your 4. That is a fact-based question. Next question. Which of the following alternative gas used for laparoscopic surgery in a patient with reduced respiratory reserve? Is it N2O, room air, helium, or argon? Okay. So the answer is helium. So this is also a fact-based question which is given in some of your books, also standard books. So carbon dioxide can cause hypercarbia, problematic in poor lung function. So helium is inert, okay, non-absorbable, avoids carbon dioxide related acidosis. So N2O is inflammable, is actually flammable, and also not preferred. N2O we never preferred. N2O is used for your anesthesia. So helium is an inert gas. It can be used in place of your carbon dioxide also. Room air and argon are not used in your pneumoperitoneum. We cannot use the room air and argon. So if there is a respiratory distress, we can go for the helium. Okay. Next question. Next question. Which of the following is not a SAGE's recommendation for the safe laparoscopic splenectomy? Use of energy source for hilum over your mechanical control, right lateral position over supine position while operating. Intraoperative transfusion should be preferred over your preoperative transfusions, and also your advice against routine use of drains after surgery. This is a surgical aspect of your general surgery. Okay, so the correct answer is your intraoperative transfusion preferred over preoperative transfusions. No. Preoperative transfusions and also optimization of your hemoglobin is a must for any surgery, not only splenectomy, but for any kind of your surgery. So SAGES recommends for preoperative optimization, including pre-op transfusion and not the intra-op. So C is incorrect. Avoid routine drains like your any surgery. Okay, left lateral decubitus position is performed rather than the right side up. B is the correct option. And mechanical vascular control is often preferred over purely energy sources because there is a high chance of bleed and also massive bleed, and patient can go to your death also. So mechanical control is the most appropriate step. your next step. That is, A reflects the common practice but may vary. Thus, C is the incorrect one. Next question. Super obesity, or what you call your fatness, is defined as BMI higher than 40, 50, 60, 35. So the answer here is A, 50. Okay. So class 3 morbid is your BMI more than 40, super obesity more than 50. So the question was your super obesity, which is more than 50, and also super obesity, which is more than 60. So I tell you, everybody should have the right BMI, should have healthy diet, and also good exercise oriented lifestyle. Okay, it is easier to say rather than doing, because we in the medical profession, we are always in a stress, and we ourselves don't take care of ourselves, and there will be obesity. But better to get it below 25, if not 25, at least below 30, at least. Next question. Guidelines for treatment of SSI are all except antibiotics given based on culture sensitivity report, source control by opening the incision, send sample swabs for pathogen identification, timely antibiotic de-escalation. So, see, all the guidelines are okay except send sample swabs for pathogen identification. Swabs are not reliable. Tissue or fluid samples are preferred. Okay, swabs are not reliable. Culture directed antibiotics are correct. Incision opening and drainage, that is your source control, is your correct. De-escalation is a part of your antimicrobial stewardness is correct. So C is not recommended. Why? Because other things are correct or has to be followed. Anyways, incision drainage followed by culture and antibiotics is more preferred rather than doing your any type of antibiotics and doing your resistant to the antibiotics. So antibiotic resistance is the most common problem that we are facing. Best investigation to localize parathyroid gland. CT scan, MRI, neck ultrasound, and system AV scan. So parathyroid are small glands, four glands which are present behind your thyroid gland, which cannot be seen in your normal scans. So it can be seen in your system AV scan. So 99 technetium system AV scan is the most sensitive for parathyroid adenoma. Okay, so USG helps but less sensitive, and CT and MRI are secondary. So the option will be your system AV scan. So the general surgery questions were quite easy to answer rather than the neurosurgery questions. Neurosurgery questions was somewhat easier in the May session, but we can expect higher or difficult questions in the November session. So we cannot be very sure. Next question. Which of the following is not an indication of LD, latissimus dorsi flap? Minor breastosis, small breasts, abdomen donor sizes is unavailable. In all these cases, we can use latissimus dorsi flap. But all breast sizes we cannot say in a broad spectrum for the LD flaps. Okay, latissimus dorsi flaps provide limited volume suitable for small breasts, moderate ptosis, and when abdominal flap is not available. But in a broader aspect, LD flap can be used for all the breast sizes that cannot be used this term. It is not suitable for all breast sizes, especially large breasts, because it will not provide greater volume. Next question. True about breast gangrene are all except few. Endocrine questions always come in any type of entrance exams like your NEET, that it be INI. There will be more focus on your endocrine questions. Diabetes mellitus is a risk factor. Higher chances of having underlying breast cancer. Tooth bite mark is a risk factor. And also sequential debridement and IV antibiotics is the treatment. So the correct answer here will be higher chance of having underlying breast cancer. So these all are true about breast gangrene, but the incorrect statement is your higher chance of having breast cancer. Okay, tooth bite, it can cause diabetic or traumatic gangrene, which is true. Diabetes is a risk factor, which is true. Treatment is your debridement and IV antibiotics, which is also true. But underlying breast cancer is not an option or a common thing. That is a false statement. Which of the following is the incorrect for hypothermia in a patient with mild trauma? So certain options were given. This is also a fact-based question. Mild 34 to 36 degrees Celsius, moderate 32 to 34 degrees Celsius, severe less than 28, and severe less than 32. So same options two times given, severe less than 32, severe less than 28. So either or one option will be correct and one option will be incorrect. So here the answer is severe, less than 32 degrees Celsius. Option D is the correct answer to this question. Trauma hypothermia classification, mild, moderate, you would know. But severe will be less than 28 and not 32. So severe less than 28 is correct, but less than 32 is not correct. That's why the answer is option D. So option C is your outdated. Okay. So D is incorrect based on the current trauma guidelines. Okay. Next question, which is a neurosurgery question, and also it is a pelvic and your spine question. True about pelvic incidence is your PI is equal to PT plus SS. Some equations were given. Anyways, we have to know the correct equation. The correct equation is pelvic incidence is equal to your pelvic tilt plus sacral slope. So what is this pelvic tilt or pelvic incidence? Pelvic incidence means the amount of lordosis that is needed for your spinal stabilization. The amount of lordosis, suppose I am sitting, I am walking, the amount of lordosis that is needed for the spinal stabilization for the natural curvature of like 11 degree with the sacrum of the lumbar spine, that is your pelvic incidence. Some patients might have some trauma, some with the age, in the some women in pregnancy, in some other scoliosis, kyphosis, there could be having some problems. So PI is equal to PT plus SS. PT is your pelvic tilt plus sacral slope. It is a mathematical equation already given in the book, already proven. This is a fact-based question, already proven, already given in your Human and Greenberg. You cannot change it. Like CPP is equal to MAP minus ICP. Similarly, PI is equal to PT plus SS. So what is this? Sacral slope, and what is this pelvic tilt. So I have given an example and also I have given a diagram here. If you come to your sacral slope, that is your highest sacrum level with the midpoint of the vertebra, okay, here. And what is this pelvic tilt? Pelvic tilt, it is like your the last five vertebra with the midpoint of S1, with the midpoint of S1. Anyways, all these things is like the common equation, and you have to remember this equation, okay? In the exam, this diagram can also come. So in this diagram, they may mark, or this they mark, this they may mark, and they might ask what is this and what other things could be there. They may mark all these things and they can ask you in the exams, and you have to correlate and give us the answers. Okay. So please go through images and charts in the books as I have told you. If you don't know the answer also, you can rule out, but the time limit will be very less and there will be stress on your mind also. The next question. Question was about a 9-year-old child with precocious puberty. Specifically, 9-year was written in the exam as told by the students, so we are not sure. And dystonic seizures, okay, paichilothermia and sagittal section and the brain MRI image was given along with it, and diagnosis was asked. So many hormonal changes and like some thalamic type of changes, hypothalamic kind of changes are given in the exams, and diagnosis was asked. So hypothalamic hamartoma, thalamic pilocytic astrocytoma, also pineal tumor, and germ cell tumor. So certain options were given to us. So the answer, what we derived after discussion, could be your hypothalamic hamartoma as per the student's recall question. If the question was something different, then we cannot say about the answer. But according to this question, the answer will be your hypothalamic hamartoma. The classical triad is your precocious puberty, and there will be gelastic and dystonic, your seizures will be there, and gelastic laughing will be there, laughing kind of seizures, precocious puberty, and also hypothalamic temperature dislocation, and that is your dysregulation could be there, like your poikilothermia, okay, and also like your there will be some type of other behavioral changes could be there because of the involvement of your hypothalamus and your thalamus. So the answer could be your hypothalamic hamartoma. MRI shows lesion attached to tuber cinereum, hallmark of the hypothalamic hamartoma. There was this some prechiasmatic lesion in the tuber cinereum, so it could be your hypothalamic hamartoma. Next question. Patient presented with weakness of the left masseter and left pterygoid muscles, left hemifacial anesthesia, and left corneal reflex was absent. So left side, many things were absent. Where can you localize this lesion to? So multiple options were given. Okay. So So options, from these options, we can localize to foramen oval and left side. Why? Because masseter and pterygoid motor branch of the V3, that is your mandibular nerve, facial anesthesia will be V2, V3. So in the foramen oval left side, that is your male, all these structures are going and coming. So this, it is like you're localizing. So it is like we know the answer, but we have to relate clinically and go back. If you go back, you can know the answers. Absent corneal, afferent lip, that is your V1 involvement is there. A lesion in the Gasserian ganglion, that is your foramen oval region, can involve V1, V2, V3 fibers together. So brainstem options would cause additional cranial nerve defects, and which is not seen here. So the answer will be your oval. If it is brainstem, there could be have some additional your symptomatic involvement, some hemiparesis like we have seen in the Benedict syndrome, Parinard syndrome. So here the answer will be your mostly foramen oval. That is your base of the skull foramens. So base of the skull foramens, the anatomy are also important for you. Next question. Which of the following is incorrect about the daily needs of a 70 kg healthy man? This is a general surgery question, or you can say a general knowledge question also, like a medicine question also. So water 2000 ml, urine 1500 ml, sodium 5 to 6 grams, potassium 100 milli equivalent. So what will be the answer here? Potassium 100 milli equivalent. So normal daily needs of water will be 2000 ml, which is correct. Urine output will be 1500 ml, which is also correct. Normally, it can be more and less also, but normally we can take in the range. Okay. Sodium 5 to 6 grams per day, correct. But potassium is 40 to 60 milli equivalent per day, because potassiums will be less in the body. So 40 to 60 milli equivalent per day is the correct answer, and not 100 milli equivalent. Okay. So incorrect statement is option D. Sequence of most common sites of occurrence of the GIST. Okay. Gastric, intestinal, stromal tumors. Okay. So what will be the area where the GIST will occur? So GIST, you must have done in your general surgery, the GIST surgeries in your GI practices also. So the common location will be stomach, more than small intestine, and more than colorectum. Among the options, option A is the correct option. The more incidence will be in the stomach, that is about 60%, more than small intestine 30%, and more than the colon or rectum, which is about 5%. So stomach, small intestine, and colon and rectum. And esophagus will be less than 1%. Thus, the option A is the correct option. Option A will be correct. Next question. Which of the following is wrong about the Fraze syndrome? What is the Fraze syndrome? It is some gustatory syndrome, and you have read about this in your general surgery, salivary gland. It sometimes comes in your neurosurgery, some questions also. So what it is? Occurs post-parodontectomy, associated with diabetes mellitus, associated with the parotid malignancies, occurs after cervical sympathetic chain is severed. Sometimes there will be, as I told you, multiple answers could be correct, some 90% correct, some 80% correct. So you have to reach to the correct answer by thinking and cross-examining and choose the maximum correct answer. Okay, so among all these things, which is wrong? Occurs after cervical sympathetic chain is severed is the wrong thing. Okay. Fraze syndrome is gustatory sweating due to misdirected auriculotemporal nerve fibers, that is your parasympathetic fibers, after your parotid surgery or your parotidectomy. Okay. So the correct answer, it occurs after parotidectomy. A can be associated with your diabetes, autonomic neuropathy also. B can occur after parotid malignancy surgeries also. C is wrong. Okay, it is not have any association with your sympathetic chain injury, and D is also false. Okay. Next question. A 60-year-old male patient presented with her jaundice, itching, and an abdominal examination. It showed a palpable gallbladder. As we know about the Murphy's law, we know if there is a palpable gallbladder, it is less likely to have gallstones inside the gallbladder. So what it could be? MRCP image was given, which was the showing classical double duct sign. Okay, so what could be the suspected etiology? Carcinoma pancreas, hilar cholangiocarcinoma, distal cholangiocarcinoma, and IPMN. Okay. So the answer here is carcinoma pancreas, that is the head of the cancer of the pancreas. Okay, so double duct sign, it is directed to your CBD and pancreatic duct. If there is a triple duct sign, means the duodenum is also involved. So palpable gallbladder suggests malignant distal obstruction could be there, most commonly carcinoma head of the pancreas. So hilar cholangiocarcinoma would not give a palpable gallbladder that we have read and studied. Next question. Surgeon is doing a laparoscopic cholecystectomy which was converted to open after a common hepatic duct, some injury or transection of about 4 mm had occurred 1 centimeter below the hilum. What would the next best step? Okay, this is the best step in the management. Sometimes a question is asked, what would be the next step? And sometimes the question is that what is the next best step that you can do? So these are some different questions that you have to focus in the exam. Sometimes in your trauma questions there will be like what is the next thing you can do, and something will be like what is the next best thing you can do, or what is the actual correct treatment that you can do. So all these things you have to read the English properly and the correct question properly. Okay, duct repair without a T tube, duct repair over a T tube, Roux-en-Y hepaticojejunostomy, subhepatic drain placement. So the answer would be Roux-en-Y hepaticojejunostomy. A 4 mm transection below the hilum near to the liver is a major bile duct injury, Strasburg type E. Okay, which is very difficult to manage. Even like gastrosurgeons are called to manage these type of injuries. Okay, best management will be definitive biliary reconstruction. Roux-en-Y hepatic jejunostomy can be done. Primary repair with or without T tube has higher stricture and failure risk and not recommended. So the answer will be Roux-en-Y hepaticojejunostomy, which is to be done by your liver surgeon or a gastrohepatic surgeon and not just a general surgeon. Next question. True about papillary carcinoma thyroid. So about thyroid, we encountered about 2 questions. Earlier also, some cancer question has come in the exam. Are all except female to male ratio is about 6:1 in carcinoma thyroid. Good prognosis for female patients. Worst prognosis for radiation include papillary thyroid carcinoma and most common malignancy of your thyroid carcinoma, that is a papillary thyroid carcinoma. So what among these are true except? Okay, so the answer is 3. Worst prognosis of radiation-induced PTC, that is a papillary thyroid carcinoma. Female to male ratio 6:1, correct. Females have better prognosis, true. Radiation-induced papillary thyroid carcinoma actually has a good prognosis and not worse prognosis. Papillary thyroid carcinoma generally has a good prognosis over the other types of carcinomas. PTC is the most common thyroid malignancy, true. Okay, so option C is the exception. Which of the following is not a component of modified child Turcotte score? As I told you, many scores were also in the exams. Urine output, encephalopathy, bilirubin, ascites. So the answer is your urine output. CTP score. Child Turcotte score includes your encephalopathy, bilirubin, okay, albumin, INR or prothrombin time. It is for your liver examination, okay, for the liver function in the cirrhosis, okay. Ascites, it can also check the encephalopathy, but urine output it does not take into your parameter. This score is also there in your general medicine also. Next question. Which of the following is not included in calculating the Q-SCOFA score? Again, another score which is also given in your Sabiston and your Bailey. In the recent modification of the Sabiston, that is your 22nd edition also, some new scores and some new type of discussions are added in your Sabiston also. So systolic BP less than 100, altered metal status, respiratory rate more than 22 mm, urine output. So what is not is there in the Q-SOFA score. So answer again is urine output. Systolic BP less than 100, respiratory rate more than 22. Okay, altered mentation, all these are present in your Q-SCOFA score. But in the Q-SOFA score, your urine output is not included. This is another fact-based and score-based question which was asked in the exam. Next question. A 62-year-old male presented with complaints of difficulty in walking, memory loss, and also inability to hold urine. So there are multiple problems. What would you suspect? Normal pressure hydrocephalus, idiopathic intracranial hypertension, Parkinson's disease, Alzheimer's disease. So, according to the symptoms, the patient has a gait apraxia, there is a dementia, there is a urinary incontinence, which is a triad. The triad name is a Hakim's triad. So, this is seen your normal pressure hydrocephalus, that is your NPH. Okay, normally we use the term NPH. Okay, normal pressure hydrocephalus. Okay. there could be an MRI finding, and they will say you that this is a MRI showing hydrocephalus in an old patient having these complaints. It is also normal hydrocephalus or normal pressure hydrocephalus seen in old patient. So what is the differentiating factor? The differentiating factor is in the NPH, if there is a MRI given, there would be hydrocephalus and there will be some normal gyrus and rectus. Another hydrocephalus will be there, that is your hydrocephalus ex vacuo. So what you will see in your hydrocephalus ex vacuo, it is also seen in your old age, and there will be hydrocephalus, but the gyrus and sulcus has been deteriorated, or the gyrus and sulcus have shrunk in size. So because of that, because of the old age, there will be some atrophy, that is your hydrocephalus ex vacuo. Hydrocephalus ex vacuo. Okay, so what do we need? So what are the other options that was given in the exam? Your idiopathic intracranial hypertension, it will not have all these things like you're able to hold urine and age problem. It will be mostly seen in your obese individuals, females. So IIH is seen in your obese individuals and females. Okay, next, Parkinson's disease, it will have some gait abnormality, some slowness of movement, dystonia, like that. Alzheimer's, there will be forgetfulness, there could be like remembering past memories but not remembering the recent memories. So these are some clues of the your options. So in this option, in this question, the option NPH is your correct answer. Next question. A young female patient undergoing elective laparoscopic cholecystectomy for cholelithiasis. So it will come under which type of surgery? Clean, contaminated, and your dirty. So this is a clear-cut example of your clean, contaminated. So the question could be what category it is coming and how much percentage of SSI in your persons. Okay, so biliary tract operations are your clean contaminated surgeries. If no infection is present, if infection is present, it is contaminated. If old, dirty, or pus is coming, means it is dirty. They will ask you the classification of the clean, contaminated, and dirty type of operations, and what are the risk of SSI in all these type of categories. Okay. Next question. Which of the following is not included in the fundamentals of laparoscopic surgery? Okay. Tech transfer, suturing with extracorporeal knotting, suturing with intracorporeal knotting, continuous suturing. In the laparoscopic surgery, we don't do continuous suturing. We use other things. Okay, like pec transfer, pattern cutting, ligating loop, okay, intracorporeal knot, extracorporeal knot, but continuous suture we don't usually take. We take a purse string suture, okay. Next question. Which of the following patients belong to ASAPS, that is your physical disability grade 3? Normal healthy patient, patient with mild systemic disease, patient with moderate systemic disease, patient with severe systemic disease. In the exam, you will cramp this 1 was what, 2 was what, ASIA 3 was that, ASA 4 was what. So please go through the charts and tables in the last 3 to 4 days as I have told you. So patient with moderate systemic disease, option C is the answer to this question. Okay, that will be grade 3. So grade 4 will be severe disease and grade 2 will be mild disease. You can see 1 is normal, 2 is your mild, 3 is your severe, and 4 is your severe systemic disease, that is constant threat to life. Okay, like he's having some heart disease in 3, but that heart disease is not able to do the work. He's in a constant threat that he can have a heart attack anytime. That is 4. 5 is moribund. He's dependent on somebody. He's having a vegetative state. And 6 is your declared brain dead already. Okay. Next question. Which of the following is incorrect for damage control resuscitation? Late blood and blood product transfusions, permissive hypotension, crystalloid transfusion, 5% normal saline is given initially. So what of these things are correct? Incorrect. So D, 5% normal saline is given initially. This is incorrect. Crystalloids, colloids, okay, all those things are given first rather than 5% normal saline. Okay, there is no 5% normal saline also, as told by the students in the recall. So also crystalloids are minimized. Okay, so one more thing I want to tell you, that like this previous question, it came ASAPS score. In our neurosurgery also, there will be some scores like your GCS scores. Okay, there could be your outcome scores. There could be like, when do you suspect brain death? There are various characteristics or categories of brain death, who will declare the brain death, at after what time and what age group you will declare the brain death. So this is a potential question that can come in the exam. Next potential question which can come in the exam is your ICP monitoring, the waves, ABC waves, what wave signifies what. So these type of questions can come in your next exam, so be prepared. The next question, which of the following is not an ultrasonography sign for thyroid malignancy? Again, a thyroid question. So multiple thyroid questions and multiple breast questions have come. That is from the endocrine part in the exam. Microcalcifications, hypoechoic lesions, increased central vascularity, wider than taller. So what is not an ultrasonography findings? The answer is D, that is wider than taller. Taller than wider is a suspicious and wider than taller is not suspicious. There are certain ultrasonographic findings in your thyroid malignancy. What are the benign findings? ISO or hypoechoic, macrocalcifications, regular border, no infiltrative margins, perihilar nodular vascularity, and absence of abnormal cervical lymph nodes are your benign findings. What are the malignant findings? You remember one side, then you can relate to other side. You remember the malignant signs, and then you can relate to the benign signs. Like malignant will be hypoechoic, taller than wider, microcalcifications, irregular border, okay, infiltrative margins, abnormal cervical lymph nodes. Also, there could be increased intranodular vascularity also. The T score. The next question is to diagnose osteoporosis when it is more than +1, -1 and above, between -1 to -1, -2.5, or less than -2.5. So the answer here is less than -2.5. So T-score value is taken along with your DEXA scan and bone scan about the bone density, the mineral density, the phosphorus, the calcium, the vitamin D levels, and also the category have been done. So more than 1 will be high BMD, that is your bone marrow density. -1 to 1 is normal. -2.5 to 1, that is your osteopenia, and when it is more minus less than 2.5, less than that, it is osteoporosis, which is significant risk factor to the woman's health after your menopause. So after that, patients are generally, when are old, more than 45 age, 50 age female comes to your OPD due to any other region, any other your problem, you can tell them to do or go for your like DEXA scan, bone scan, T score, calcium levels. If all those scans not there, you can go for your calcium levels, you can go for your phosphorus levels and check the bone mineral density. The next question, which of the following would not be seen with increasing age? Increase in inflammatory cytokines, decrease in autoantibodies, decrease in immunity, decrease in differentiation of naive T cells. So as we age, decrease in differentiation of naive T cells, that is our body's ability to fight with the other organisms, decrease in immunity is seen, increase in inflammatory cytokines is seen, and decrease in autoantibodies is not decrease, it is increase in the autoantibodies. So there will be more amount of your autoimmune diseases, there will be a chance of your cancer, there could be a chance of some genetic diseases which will produce or show effects after certain age. So obviously this will increase with your age. Next question. A 7-year-old child was presented with headaches and fever episodes. An MRI brain image was showing a right parietal lobe space occupying mass lesion with surrounding edema and inset DWI. MRI picture was also there showing diffusion restriction within that region. So diagnosis is cerebral abscess, cerebral mets, cerebral AVM, and cerebral hematoma. Like some few slides back, again a big type of question, but the question at the end is asking something different. Here it is asking about DWI, in which image there will be DWI restriction. If we know the answer, we can put the right answer. It is not about the age and the child, it is about the image and the relationship, what we can see. If you know it, you can mark the right answer. So the right answer here is cerebral abscess. Diffusion weighted imaging restriction is classic for abscess. So when it is restriction, it is cytotoxic edema, abscess is inflammation, your any type of infection, acute demyelination. If there is increased diffusion or increased DWI seen in your cerebrospinal fluid, like your arachnoid cysts, okay, epidermoid cysts, Okay, so in all those things, there will be increased diffusion. In other cases, there will be decreased diffusion. One more thing that you have to remember is between the difference between DWI and ADC. So if the diffusion restriction is there, means there will be your ADC low. This is ADC low. Okay. If the ADC is high, that means your DWI is low. Okay, so this is how you classify the images. And then there will be T2 shine through images, which is usually for vasogenic edema. T2 shine through images are for vasogenic edema. Vasogenic edema is mostly seen in your tumors. Okay. Next question. MRI brain showing a left parietal space occupying lesion without any midline shift or cerebral edema, and a classical hemosiderin ring was surrounding this lesion. So this is again a MRI based image. There is a space occupying lesion, but there is no midline shift, no edema. How is that possible that there is a tumor or something, an abscess, there is no edema, and there is a classical hemosiderin ring? So the diagnosis could be cavernoma, astrocytoma, METS, ependymoma. So the answer is your cavernoma. You can see there will be having a popcorn appearance in the cavernoma with a hemosiderin ring, which is a classical finding of your cavernoma. We have completed the cavernoma detailed in our neurovascular classes. Okay. Next, astrocytoma will have edema. Metastasis will have edema. Ependymoma will have some calcifications. It will also have some type of edema. So the ruling out option is your cavernoma with a hemosiderin ring, which is in the neurovascular our classes in the app. Next question. For pyogenic vertebral osteomyelitis, particularly for the bacterial osteomyelitis, all are true except most common site is the thoracic vertebra, most commonly associated with your genitourinary infection. Lumbar vertebral involvement is due to Batson venous plexus and more commonly occurs in females. So all are true except your option A. Most common site is your thoracic vertebra. So no. Most common site is your lumbar vertebra in this type of infections. In your METS, it is thoracic. Okay. Please remember this point. If it is METS, then it is thoracic. Okay, but as it is infection, it is your lumbar spine. So most common will be lumbar due to high blood flow and Batson plexus. So Batson plexus is for the lumbar involvement. Option C is true, and it is that is why there will be lumbar involvement more than the thoracic involvement. Next question. All are true about the tethered cord syndrome, except maximum changes are seen at point of traction and they reduce as we go cranially and caudally. Okay, both the corners and nerve rootlets get stretched under tension. Early bladder involvement is seen. Pathophysiology is ischemia. As a neurosurgery doctor, I would say this is a difficult question for the INISS level exam. Okay, so knowing the right answer is difficult. So the right answer will be option A. That means it is the wrong answer. All the options are true except option A. Maximum changes are seen at the point of traction and they reduce as we go both cranially and caudally. This is the wrong option. In your tethered cord syndrome, the maximum pathological changes, ischemia, stretch responses, and any type of things that is your bowel bladder involvement occur distally near the tethering point, that is near the tethering of the cord. Okay, but neurological deterioration is not like your tethering of the cord in the sacral region. Okay, but neurological deterioration is not reducing cranially and caudally in such a linear manner. This statement is your inaccurate statement. Okay? Option B, C, and D are true. Stretching of the corners and the nerve root occurs. As I told you, early bladder involvement will be there. Ischemia is the core pathophysiology. So the answer is option A. Also, one more potential question that may come in the exam is the cornus and cauda dissimilarities, and cornus and cauda, where does it happen? In which conditions? That may come in your exams. Next is your next question. True about the syringomyelia. What do you mean by syringomyelia? There is a dilatation in the central cord. Okay, or all except what do you mean by syringomyelia? Suppose this is the spinal cord. Okay, the vertebral body and the spinous processes. We know there will be 3 layers of the dura and there will be a cord. But suppose this is the cord, there will be a dilatation in the cord. Means there is some kind of fluid in the cord, which is known as a syringomyelia. If there is a fluid in the cord, there will be compression on the nerve roots, and because there is compression on the nerve roots, the patient will have symptoms. So this is about the syringomyelia in a just small diagrammatic manner. So where it is present, except the options are bladder involvement, Charcot's joint, ataxia, coughing, straining alters neurological findings. So you can see from the options what is Charcot's joint. Charcot's joint is like a diabetic joint, some foot arthropathy, some joint problem which is not related to your spinal cord. Okay, so the answer will be a bladder involvement. Okay, see, early bladder involvement is not typical of syringomyelia. Okay, syrinx affects spinothalamic fibers or your tracts. Disseminated anesthesia will be there. Charcot's joint will be there. Ataxia will be there. Cough and strain-related symptom will be there. So anyone will think like this, but it's not like that. There will be other joint problems. Because of this pressure, I can have Charcot's joints in my fingers and arms also. So bladder involvement will not be early. Okay, and there will be cough and strain related symptomatic points and changes are all typical. Okay, so it's like not about the bladder involvement earlier. Next thing they might ask in the exam is about the hydromyelia versus syringomyelia. Hydromyelia versus syringomyelia. Okay, next, true about Neuralink are all except this is a new thing in the in our technology. Okay, working to create a brain machine interface links brain via chip to an externally fitted prosthesis and help control it. Okay, works as a bridge to bypass your damaged spinal cord segment nerves and link brain to peripheral nerves. Can you guess who is talking or who is working on this Neuralink? Elon Musk. Elon Musk, who is having the giant Tesla center and everything, he's working with coordination with certain centers in the US about this Neuralink because he wants to control the brain through a chip. They want to put the chip and want to control the brain and spinal cord. So this is a type of your creates brain machine interface. Okay, so connects brain implant to external prosthesis, works as a bypass for spinal cord injury to control limbs, like demonstrated in animals, like your robotics, like your prosthesis. It can help with our mind control, it can help move our limbs in quadriplegia. If there is a paralysis, it can take the help of the mind to help the movement better, like a motor system under development in the humans. This is about the Neuralink. So option D was something which was not correct. Okay. Next question. Not a cause of obstructive hydrocephalus. We know there are two types of hydrocephalus. One is obstructive, one is non-obstructive. Obstructive means there could be some anatomical problem. Because of the obstruction, there is hydrocephalus. But non-obstructive means there is no anatomical problem, but maybe because of some infections, some ventricle problem, there is a hydrocephalus. So it is like a non-obstructive hydrocephalus. Okay. So acum aneurysm causing subarachnoid hemorrhage, dorsally projecting tegmental tumor, anterior third ventricular cyst, okay, and tectal plate glioma. So not a cause of these obstructive hydrocephalus is your acom aneurysm causing SH. SH means there is a bleeding. Because of the reaction, there is a adherence and there is a hydrocephalus. So there is no actual mechanical or anatomical obstruction. So that is why it is not the actual cause of your obstructive hydrocephalus. Okay, so acum aneurysm SH, communicating hydrocephalus, not obstructive. The other causes of mechanical obstruction will be tegmental tumor that may cause aqueductal obstruction. Okay, anterior third, your ventricular cyst that can cause your foramen of Monro obstruction. Tectal glioma can cause aqueduct obstruction. So these are some causes of your obstruction. Okay. Decreased plantar flexion and loss of sensations over the lateral side of the sole is due to the injury of femoral nerve, posterior tibial nerve, peroneal nerve, and sciatic nerve. So you have to know about the nerves and the distribution of muscles and the jerks. That is your deep tendon reflexes. Okay. So as you all know, the basic ankle flexion or ankle plantar flexion is by your posterior tibial nerve, that is your S1, S2, is also for your ankle jerk. Plantar sensation is by the nerve root, peroneal nerve, L5, S1. The lateral side of the foot is again peroneal nerve L5 S1. Next, that is your dorsiflexion, ankle dorsiflexion. Ankle dorsiflexion is by your deep peroneal nerve, that is by your L4, L5. So here particularly there is decreased plantar sensation and decreased plantar flexion, and also there is a loss of sensation of the lateral side of the foot is due to injury of what nerve? So two options are nearby here. That is your posterior tibial nerve and also the peroneal nerve. But because there is a decrease in the plantar flexion, which is mostly supplied by a posterior tibial nerve, so here the plantar flexion by the gastrocnemius and soleus complex is more important. So the sensations of the lateral and entire plantar surface is also lost. So the correct answer in this question is your posterior tibial nerve. Okay. Few other questions that come in the exam is about how do you know about this loss of sensations? What nerves are lost or affected in your foot eversion? What nerves are affected in foot inversion? So please go through it multiple times so you don't confuse in the exam and you can mark the options very fast. Next question. A 45-year-old patient presents with light lower limb radicular pain and right side foot drop. So least likely finding will be positive SLRT, right far lateral foraminal L4 L5 disc prolapse, right posterolateral L5 S1 disc prolapse, and sensory loss along the right L4 dermatome. So this was a multiple questions of various dermatomal your findings. The least finding or the least correct or the wrong answer among this is D, sensory loss among the right L4 dermatome. Foot drop, as I told you, will be for L5 foot or root dermatome. So SLRT, that is your straight leg raging test, will be positive in L5 S1 root irritation. For far lateral disc prolapse, that is your L4 L5 disc, can hit the exiting nerve root also L4, that is your upper nerve root. If central and your lateral, it will be descending nerve root as we have discussed. But far lateral will have the opposite or the above nerve root, that is your L4 nerve root, can also affect the L5. Okay, so the posterolateral L5 S1 disc, classic cause of your L5 radiculopathy. Okay, so L4 dermatome sensory loss, it is not there, so does not correlate with L5 related foot drop. Okay, so just go through the options, you will get to the answer. So a 45-year-old patient presents with the right lower limb radiculopathy was there and a foot drop. So there could be SLRT positive, there could be far lateral foraminal L4 problem, there could be right posterolateral L5 S1, that is L5 problem, but sensory loss among the right L4 dermatome is not related. Okay, there could be some pathology in the D option, something above. Next question. All the following are surgeries done for the cervical OPLL. What is OPLL? Ossified posterior longitudinal ligament. So where it will be present? As we know, this will be suppose the cervical spine. Okay, the vertebral body and the spinal nerve roots. There will be our three layers of your meninges and spinal cord. Okay, so also we will have certain ligaments attached. We will have certain ligaments which are attached. Okay, so it will be present in the vertebral columns. There will be your anterior longitudinal ligament in the front of your vertebral bodies. Here will be anterior longitudinal ligaments, and here just behind your vertebral body and in front of the dura mater, and just behind the vertebral body you will have the posterior longitudinal ligament. So here the posterior longitudinal ligament will be there, which is normal. Posteriorly, similarly, dura, ligamentum flavum, that is the yellow ligament, dura, ligamentum flavum, yellow ligament, and the spinous process. These are all common things which is present in everyone, but due to pathology, due to certain factors, due to aging, okay, because of genetics, these can become thickened. So once this becomes thickened, suppose ligamentum flavum in the backside and OPLL, ossified, means thickened posterior longitudinal ligament, it will compress the nerve, it will compress the dura, so it will compress the your cord. So these things will produce your cord symptoms, okay, spinal cord symptoms, because not because of the spinal cord problems, but because of the outside problems compressing on the dura and the cord. So it will present as a cord symptoms or the cord problems, okay. So All the following are surgery are done for the cervical OPLL except only cervical laminectomy, only cervical laminoplasty, cervical discectomy with fixation, okay, anterior corpectomy with cage fixation. Okay, so only was specifically mentions that I have given here as told by the students who have appeared for the exams. Okay, so the answer here is only cervical laminectomy. Laminectomy alone is inadequate, causes post-laminectomy kyphosis, incomplete decompression. Other options are two: carpectomy for cage, mainly anterior approach, discectomy for fixation, and again anterior approach. Laminoplasty preserves the stability, but only laminectomy. Only laminectomy, that means only posterior. Lamina is in the posterior. So only laminectomy, that is the posterior approach, is not useful in these cases. Okay, so this is a surgical aspect of the clinical problem and the surgeries that could be done. Which of the following is not an indication of temporary abdominal closure? A general surgery trauma questions: damage control surgery, triage, intracutaneous fistula, intra-abdominal hypertension. This is a basic question. I hope you can understand and you know about all these things. Which of the following is not an indication of temporary abdominal closure? And we will do carry out and the permanent closure after a few days. After the stabilization, we will carry out the permanent closure. Okay, so it will be used in your damage control surgery, intracutaneous fistula, intra-abdominal hypertension, but not in triage. So temporary abdominal closure is observed in all these cases. Triage is not an indication. Triage is not an indication. It is triage is for other, like your trauma cases, like there is a disaster. In there, we take out the triage. In casualty, we take out the triage. So here, triage is the incorrect option. So this is a gist of all the questions. That was like a recall session for the May INISS neurosurgery. Also, I will suggest you that in your books also you just go through the basic surgical options, the indications of surgeries in neurosurgery parts means mostly that what surgery are used for what conditions. If suppose a simple question comes, you should not miss the answer. So in the Greenberg and Newman, there will be certain charts and surgical options will be given. At the end, I will tell you, be relaxed. Don't take stress, just revise and go and give the exam with a free mind. I hope you all get a desired seat and desired rank in your for getting a seat in your desired college, and you all prosper in the exams. Thank you. Thank you, students.